Hello friends, in today's class we will discuss regarding retinitis pigmentosa. So what is retinitis pigmentosa? Its inheritance, pathogenesis, symptoms and signs, the causes of vision loss in RP, and ocular and systemic associations of RP and atypical RP. So coming to retinitis pigmentosa. So retinitis pigmentosa is a group of progressive, hereditary disease which affects photoreceptor and retinal pigment epithelium layer. So here the photoreceptors are rods and cones, and here rods are affected more than cones. So it is also called as retinal degeneration, primary pigmentary dystrophy, or rod cone dystrophy. Now coming to the inheritance. The inheritance pattern is either sporadic or hereditary. So in almost 40% of the cases are sporadic, whereas 60% are hereditary. So here in the sporadic, it involves rhodopsin gene. Whereas in the hereditary we have 20% is autosomal recessive. Autosomal dominant is almost 10 to 20%, and we have X-linked, this is 10% to 15%. So it is least common but most severe. This autosomal dominant one has best prognosis because it is least severe. So the most common chromosome involved here is due to involvement of rhodopsin gene, that is RP1, which is located at chromosome 8. So here it is seen in 1 in 5,000 people. It appears in the childhood and slowly progresses. So males are affected more than females, 3:2 ratio, and it is involved the bilateral eyes. Coming to the pathogenesis. We have some theories of pathogenesis. Okay, so here we have the theory of abiotrophy. So according to this theory, what happens at the equator, rods, cones and the RPE are developed embryologically. So because they develop first, they will undergo degeneration first. Okay, that RP and retinal photoreceptors. So therefore equator is first involved where the degeneration is seen. Then along with this we have apoptotic damage to rods and cones and the RPE cells. So this is the theory of apoptosis. In which the photoreceptors, that is rods and cones, are involved and the RPE cells are involved. So what happens to rods and cones? They are degenerated. In the segments are normal, so there is reduction in the number of photoreceptors. So there is reduced in visual acuity and visual fields. Whereas in the RP cells, these are pigment epithelial cells, right? So these release the pigment that is melanin, or the melanin, it can be ingested by the macrophages. So this accumulates at the inner layers of the retina around the blood vessels. So these cause bony spicules. Okay, so the triad is the bony spicules, attenuated arteries and a pale optic disc. So we'll discuss it in the science. So here coming to the symptoms. So symptoms include night blindness, which is the earliest feature, and there is delayed dark adaptation, and loss of peripheral vision, and slowly it will lead to complete blindness. There can be color vision defects, okay. Coming to the signs. So we have this triad, that is bony spicules or the pigmentary changes. So we have discussed here how these bony spicules are formed. Then is arteriolar attenuation, so there is sclerosis of blood vessels, thickening, okay, and there is waxy pallor of disc. So this is due to fibrous proliferation of glial cells. Resulting in thick preretinal membrane, and this will slowly cause consecutive optic atrophy. So coming to the fundus diagram, we can have this is the disc. So this is pale disc, thin arteries, and bony spicules which are present in the periphery. So this is the characteristic appearance of retinitis pigmentosa. In the macula there can be maculopathy, atrophic cellophane type, okay, and in the signs we can also find visual field changes, that is ring scotomas due to equatorial degeneration, right? And we can also form on the visual testing. So with perimetry there can be ring scotomas, and on color vision testing there can be blue yellow defects, dark adaptation is prolonged, and in ERG there is reduced scotopic and combined response in the early stage. In advanced cases it is extinguished. Perimetries, there is ring scotoma, in early stages leading, and finally there is tunnel vision, then there is complete blindness. Okay, then we have what else, contrast sensitivity also can be tested, and all. Okay, now coming to it's the causes of visual loss. The causes of vision loss in this are retinal degeneration, cystoid macular edema, and posterior subcapsular cataract. So the retinal degeneration we all know is due to loss of photoreceptor cells, and which leads to reduced visual acuity. Then there is cystoid macular edema. It is secondary to chronic low-grade inflammation. Okay. And posterior subcapular cataract is also due to that chronic in low-grade inflammations which cause this. Now coming to the ocular associations. It is ocular and systemic. Ocular associations include high myopia, primary open angle glaucoma, microphthalmos, keratoconus, and posterior subcapsular cataract. And the systemic associations include syndromes like Lawrence-Moon-Bedell syndrome, in which there is polydactyly, obesity, hypogonadism, and intellectual disability. And we have Cockayne syndrome, in which there is dwarfism, nystagmus, and deafness, Refsum disease with ataxia, peripheral neuropathy, and cardiomyopathy. I'm just mentioning the important ones. Usher syndrome. So RP with deafness. Then we have narp syndrome. Neuropathy, ataxia, and retinitis pigmentosa. And kearn syndrome is external ophthalmoplegia with retinitis pigmentosa. Okay, now coming to atypical RP. So we have cone rod dystrophy. So in this, cones are affected more and first than rods. So there is defective color vision and central vision is affected first. Then retinitis pigmentosa, sine pigmento, in which there is no pigment changes. Then sectoral RP, in which only one sector is affected. Then we have central or inverse RP, in which pigmentary changes first affect the macula. Then we have retinitis punctata albescens, in which there are white dots instead of black dots. Albescens means absence of pigment. Okay, so these are the atypical RP. So in the next class we will discuss regarding the treatment of RP. So this is very important recent advances question. Thank you.